we are finding that psychosocial interventions are promising solutions to improve mental health outcomes in rural Ethiopia among poor households. But we are also seeing that design, delivery, and context likely matter for impacts.
Welcome to Global Dispatches, a podcast for the foreign policy and global development communities and anyone who wants a deeper understanding of what is driving events in the world today. I'm your host, Mark Leon Goldberg. I am a veteran international affairs journalist and the editor of UN Dispatch. Enjoy the show. Today's episode is produced in partnership with the CGIAR Research Initiative on Fragility, Conflict, and Migration for a series that examines what works to improve the well-being of people in fragile and conflict-affected settings. CGIAR is a global partnership that unites international organizations engaged in research about food security. We're calling this series From Fragility to Stability. And in today's episode, I host a roundtable discussion with three experts about how to better support mental health through social assistance in fragile settings. You'll hear from Michael Mulford of World Vision International, Adiam Hailemichael, an economist at the World Bank, and Melissa Hidrobo, Senior Research Fellow at the International Food Policy Research Institute, IFPRI. You can access this episode and find other episodes that are part of this series by going to globaldispatches.org. Thanks, and now here's our conversation. Before we start, I would just like everyone to introduce themselves so listeners can put a voice to a name. Michael, let's start with you.
My name is Michael Mulford. I'm the Chief of Party for the Strengthening PSNP4 Institutions and Resilience in Ethiopia with World Vision.
And Adiam.
Adiam Hailemichael. I'm an economist with the Africa Region Gender Innovation Lab at the World Bank, and I do quite a bit of work in Ethiopia, including on mental health.
And Melissa.
Hi, everyone. I'm Melissa Hidrobo. I'm a Senior Research Fellow at the International Food Policy Research Institute. A lot of the work I do also is on social protection and mental health.
Michael, I'm going to start with you. Can you describe the mental health challenges you have witnessed in your work in Ethiopia?
In Ethiopia, there's been a period of unfortunate series of shocks, both climactic and man-made in nature, conflict as well. In addition, we're working here with a population that is itself already highly vulnerable. So the program participants in this program are those participants of a large social safety net program known as the Productive Safety Net Program here in Ethiopia. And intentionally, these are in areas that are more drought prone or other factors leading to food insecurity. So these are typically really highly vulnerable households in rural areas in Ethiopia. In my own experience, I've talked with and met people suffering both from kind of what you'd imagine idiosyncratic shocks of sickness of a family member, a breadwinner, and selling off assets to try to support that recovery of that sickness, people that have lost family members due to sickness. Or I've also spoken with female-headed households where they've put all of their resources into a planting season only to have a drought come through or pests come through and essentially wipe out those results. So just facing really extreme conditions on the edge of survival and then having this impact their mental health. And then in addition, unfortunately, we've had a period of conflict here in Ethiopia where people have just experienced extreme atrocities, loss of their assets or destruction of things in their community, and as well loss of family members or breadwinners or others of their close immediate family. So talking with people in these settings, it's really hit me of how many have struggled to cope. And so this reflects in people's often describing very kind of common symptoms associated with depression or anxiety or stress, of just finding it difficult to have energy, low mood, racing thoughts, or inability to sleep, low appetite, and social self isolation, easily angered, and other things. So people have reflected that this wasn't normal for them, but they've kind of, in reaction to some of these shocks and things they've experienced, had these symptoms that they're describing, often not knowing the terminology to put with them, but reflecting common symptoms associated with these common mental health illnesses that I've mentioned.
So, Michael, I wanted to stay with you. Having just explained the scope of the mental health challenges that you've experienced in the course of your work in Ethiopia, I'd love to have you just discuss some of the different solutions that you've tested in Ethiopia to address these mental health challenges. And in the process of implementing these solutions, what setbacks and breakthroughs have you experienced?
In many low income and middle income settings, one of the things that's motivating for researchers and mental health practitioners to develop different types of approaches is this extreme gap in services. So Ethiopia is no different. There's very limited psychiatrists and psychologists that offer mental health services in clinical settings as compared to the needs that are there, and especially the needs in the rural areas where we work. So we've identified, worked with collaborators at Columbia Teachers College and Johns Hopkins University initially to identify an intervention that was targeted towards specifically dealing with depression. So interpersonal psychotherapy in groups. It's a WHO approved methodology that's evidence based and has very clear structure for it. So it's something that non specialists, after receiving some intensive training and supportive supervision, can deliver over a 12-week period. Additionally, we've more recently identified a more transdiagnostic approach for addressing not just depression, but other common mental health illnesses such as stress, anxiety, or post-traumatic stress. That's called Group Problem Management Plus. Again, another WHO approved and one that has evidence for being effective in similar settings. It's slightly shorter, so it's 5 sessions that really focus on teaching practical skills around stress management, problem solving, behavioral activation, and social skills to improve mental well-being and daily functioning. And perhaps one additional point to mention, both of these interventions are group-based, so delivered with a small number of clients that are identified or screened in as exhibiting some of these symptoms that I described previously. To your second point about challenges and breakthroughs, so I can say that initially there was some pushback. So in some of the areas or contexts we work, it was seen as something, perhaps a perception of mental health illnesses were something that was an urban issue, that these weren't issues for the rural settings we were working in. But over time, when people really saw, first of all, those that were identified and screened in as having these symptoms and seeing the impact, a really dramatic impact for participants in these programs, we really had feedback not only from the participants, their family members, about how someone really came back to life. They kind of gave it in very dramatic terms of the change that they saw in their loved ones, their family members, and then even among other stakeholders with the Ministry of Health and community members, really seeing the effectiveness of these programs brought them on board with recognizing that these were issues or mental health challenges that could be addressed with interventions such as these, relatively short but practical and intensive group therapy sessions.
Adiam, I wanted to turn to you. So Michael has been describing and discussing some of the rural mental health challenges and solutions. The World Bank has also been implementing some mental health interventions in urban areas of Ethiopia. Can you describe how the urban population presents different challenges from rural ones?
In essence, the nature of the challenges faced in urban areas are similar to that of the rural areas, but in terms of the specific nature of the challenges faced, these are heterogeneous. Depending on the groups that you have under consideration. For young people, it's mostly related to the mental strains that they face in terms of job search, finding employment, and getting themselves involved in an income generating activity. It could also be, for instance, the specific subgroup that I mostly work with, women entrepreneurs. And the kind of mental health challenges that they faced are mostly driven by double, triple burdens of, for instance, women facing specific constraints in terms of accessing finance for their businesses, accessing labor for their businesses, and also navigating the business regulation environment. There is a lot of evidence showing that women are disproportionately affected by those constraints. In addition to that, there is the challenge of also having to deal with domestic responsibilities, caring for the household, members for children, and taking care of household chores. So, like a combination of these factors makes them a bit more exposed to mental health challenges. And then there is also the additional layer of resilience towards different kind of shocks that they face. So during the COVID pandemic, although every business did experience loss of revenues, but women-owned businesses had way much bigger losses in terms of revenue and also had way much higher probability of shutting down their businesses. And this we also tried to look at the time whether this sort of translated into a deterioration of their mental health. And we did see that the loss of income was accompanied by a significant deterioration in their mental health outcomes.
And similar to my question to Michael, can I have you just describe some of the solutions and interventions that the World Bank has tested and some of the challenges and breakthroughs that you've experienced in implementing some of those interventions and solutions?
And we observed that the pandemic was leading into significant deterioration in mental health outcomes for women entrepreneurs. What we did was we went on scoped for different alternative mental health interventions that were out there, because there is a significant service gap in mental health service delivery in Ethiopia. We opted for a non-specialist based kind of solution that we could easily provide to the women, that they could easily understand and apply in their lives. And we came across a self-help tool called Doing What Matters at Times of Stress. This is a publicly available acceptance and commitment therapy-based intervention that was designed by the WHO. It's available on their website. And then what we did is we adapted that tool to the urban and women context. And then we distributed it to women. And then in addition to distributing the book, we also complemented it with 5 rounds of phone calls from, again, non-specialist mental health providers that were trained in collaboration with a partner called the Ethiopian Medical Association. And the book, not only is it publicly available, but it's quite easily understandable. It uses pictorial illustrations, and the kind of exercises that it highlights are easily applicable, which made it quite easy for the woman to apply the lessons.
And Melissa, I'm going to turn to you now. In collaboration with World Vision, IFPRI has been conducting rigorous impact evaluations to see what works and what doesn't in terms of mental health interventions in Ethiopia. Can you describe those findings thus far?
So as you mentioned, IFPRI has been collaborating with World Vision on studies specific to mental health for about the last 5 years. And we've done 3 different RCT, so randomized controlled trials, which are the gold standard to identifying the impacts of these psychosocial interventions. So the first one that we conducted in collaboration with World Vision was trying to estimate the impacts of the interpersonal psychotherapy for groups, IPTG, intervention that Michael mentioned earlier. And what we found was that among women who were depressed, an integrated intervention, which included cash transfers and the IPTG, was the most effective at improving women's mental health, so decreasing depressive symptoms. A different study, the second study that we then conducted with World Vision again, was looking at group problem management plus, so a slightly less intensive intervention, as Michael mentioned before. And here we try to estimate the impacts of GPM plus with or without cash transfers. And again, we find that GPM plus with cash is the most promising solution for improving mental health and economic conditions as well. But in this second study, we found, or our finding, because we're currently looking at the impacts, we're finding that impacts may depend quite a bit on the local context. The first two studies that I mentioned were conducted in Amhara and Oromia, and then the third study we turned to Tigray, and we're again looking at the impacts of how to try and examine how to scale up GPM Plus in Tigray, in particular whether delivering GPM Plus through large-scale government health structures using health extension workers was feasible or effective. And so here, again, using a randomized controlled trial, we assess the effectiveness of GPM Plus delivered either by health extension workers, government-employed health extension workers, or by local facilitators engaged by an NGO. And again, we are currently conducting this study, so we're finding that while health extension workers did lead to improvements in mental health, impacts are larger when they're delivered by local facilitators engaged by NGOs. And so in this study, it's not completed because we're still looking to see whether impacts are sustained 1 year later. So to sum up, across all three studies, we are finding that psychosocial interventions are promising solutions to improve mental health outcomes in rural Ethiopia among poor households. But we are also seeing that design, delivery, and context likely matter for impacts.
So, Michael, can you describe what you've learned from this evidence generated from this work thus far, and how have you used it to develop and or plan or change your programming going forward?
As Melissa described, we started off with a focus on depression. Actually, we were motivated initially with a focus on maternal depression. However, we found that there was significant levels of paternal depression as well. So we did adapt our programming to give equal focus or attention on men's depression. I should also mention this is integrated in with a larger multi-sectoral program. So really with this focus on and understanding awareness that households or individuals in these settings are facing a number of constraints that are in many ways trapping them in poverty conditions or of poverty. And so we see this as perhaps one of those constraints is this mental health challenges that they may be facing, but recognizing there's a number of other constraints that may be both influencing their mental health, but then also preventing perhaps sustained effects or improvements in other outcomes. So as Melissa described, we have seen impacts that have been in these combined groups. So when we've combined treatments of livelihood support together with mental health and other program components, we've seen impacts not just in mental health outcomes, but also in some psychosocial outcomes related to happiness and well-being, and then also physical well-being. So we've measured really marked impacts in women's nutrition, for example, that were sustained after 1 year of some of these interventions being completed. So again, the combination of treatments and done together in a holistic manner seems to really be important to have a sustained impact for people suffering from mental health illnesses, but also in other conditions of poverty that are influencing their overall health and well-being. Other things that we are learning, as Melissa described, are just coming from testing different modalities and implementing these in different contexts. So some of our contexts, as I was mentioning earlier on, have been affected by significant periods of conflict, and we're finding some differential results on that basis. So this will be kind of, again, interesting to inform how we target and how we adapt our programming to the different contexts we're working in. And then also just targeting itself. So there's different thoughts out there in this field and in the evidence of whether some of these programs or interventions should really be targeted to the worst off or maybe more severely depressed or those suffering more significantly from other mental health illnesses versus maybe this is something that's just beneficial for a general population and can help a lot of people. So for us, we're finding, I think some of the evidence is really pointing to a more targeted approach, both in terms of reaching people that are most in need with these interventions, but also this kind of dynamic that comes within a small group where individuals themselves are often expressing some of these things for the first time. So recognizing that other people have had thoughts of killing themselves, that have had significant symptoms that they may have not even shared with their partner or spouse and are opening up in a small group setting. We've seen this as just a powerful way, both for immediately finding this common ground and kind of openness to addressing some serious issues, but then also the support that then comes within these group settings for people to encourage and build up and support their fellow group members over time. We've actually found, even after these groups have finished, after the 5 weeks or 12 weeks, that these groups really continue meeting and people derive a lot of support and encouragement and ability to kind of continue practicing some of the skills and things that are promoted as a part of these interventions after they've been completed.
Adiam, the World Bank is also conducting rigorous impact evaluations to see what works and what doesn't in terms of mental health interventions in urban Ethiopia. Can you describe those findings thus far?
What we found from this proof of concept impact evaluation was, in the short term, the intervention significantly reduced mental health outcomes such as psychological distress, depression, perceived stress, and even functionality. So what we did is, once we established that the intervention does work in the short run, what we try to do is do a follow-up and much bigger impact evaluation study, now covering a wider geographical area. The first study was only focused in Addis Ababa. The later one, the one that is currently ongoing, is in 4 different cities in urban Ethiopia. And the purpose of this follow-up study is to look at, one, the long-term impacts of the intervention. Second, whether the improvements in mental health outcomes, do they lead to improvements in economic outcomes, such as business performance and income for the household? And in addition to that, we also aim to look at the experience of gender-based violence and intimate partner violence. So now we are currently conducting a bigger scale impact evaluation. We have just completed a final round of surveys, so we should be coming with early results soon. These 2 studies were feeding to each other. We didn't wait for this scale up study for us to use the evidence that we have to inform the design of additional programs. For instance, once we established that the intervention does improve mental health outcomes, in the short run, we worked with the Entrepreneurship Development Institute, which is a semi-autonomous institute that helps craft entrepreneurship training programs for different subgroups in the country. We work with them to incorporate a psychosocial training, which also relies on this Doing What Matters at Times of Stress tool. It has already been delivered to over 3,000 beneficiaries, I believe. So we run our impact evaluations, but then we also use the evidence to inform the design of the policies programs in the country.
And Michael, I wanted to turn back to you. What do you see as the potential for scaling these types of interventions, and what are some of the challenges you foresee? And what role does the evidence generated by studies play in the plans for scaling of these kinds of programs?
One of the critiques, I think, in this literature is that many of these interventions have been implemented kind of at a pilot or smaller scale level, have shown to be effective, but really kind of following these positive results, perhaps not a big effort to integrate these services into larger health systems or other things after the research. So that's really, as what Melissa was describing, our latest study is motivating a direction of trying to implement or see what the impact could be of implementing through a government health extension system. So this is something that we are testing in this one context in Tigray, this region that's come out of a significant conflict. It's actually one that, from my initial scoping visits at all levels with community members up to highest level officials within the Ministry of Health, everyone reflected that this was one of their strongest felt needs, not just something out there, but they themselves personally needed this support. So it's something that was really pointed out and recognized as being a priority for strong consideration with a lot of other actors or people coming in with perhaps smaller or one-off solutions. They saw this as really one of those potential programs to meet some of those needs, especially at a community level, in a structured and supported format. Now, I think one of the challenges that we already observed in this implementation was that these are staff that have many, many other responsibilities and pressures on their time. So there might be a polio campaign or a vaccination campaign, another thing that's being rolled out across the region that these health extension workers are responsible for leading and conducting. So oftentimes there's a huge demand on the time for people that are also called upon or asked to support these mental health interventions. So for us, I think one of the interesting things going forward will just be looking at, is it possible for this to be sustained within a government system? And even with all of the support and recognition of its importance, is it something that can be consistently delivered at a high level of quality? So unlike perhaps other interventions, we're dealing with often a very highly vulnerable population that there also needs to be very strict safety and referral protocols in place. So if someone does express a high level of suicidal ideation, for example, there needs to be a careful protocol in place that will refer them up to clinical services and other services. So again, it's not something that we would recommend or suggest can just kind of easily be implemented or scaled up without a really careful attention to quality, adherence to the protocols that are associated with these programs, and then just a strong supervision in place in case there are special cases that come up or needs that are identified, that there's a strong supportive supervision that can support those frontline facilitators in dealing with those sensitive cases.
Adiam, based on the research findings and your own experience, what do you think are the next steps or future direction for improving mental health in Ethiopia?
So Ethiopia has quite limited trained service providers for mental health interventions. So it is important to identify interventions that are easily applicable, interventions that you can relatively easily deliver, of course, without compromising the quality of these interventions. And I think the question of identifying those interventions that you can easily scale is an important question that needs to be answered. But then you also need to have at least a mechanism in place to make sure extreme cases like say suicidal ideation, you need to make sure that you have services in place for this kind of extreme cases. But then for the moderate cases, it's important to think about interventions that you can easily scale and ensure the reach of these interventions.
And Melissa, same question to you. What do you think are the next steps or future direction for improving mental health in Ethiopia?
In addition to finding ways to scale up these programs, I think for us, one thing we found in our second study, which was done in Amhara and Oromia, is, as Michael mentioned, and as I mentioned earlier, context really mattered and conflict mattered. And we still don't really understand the mechanism or why. We're still trying to figure out why it mattered so much. But what we're finding is that in places where there was ongoing extreme conflict during the study, so this is not post-conflict, this is sort of during the study, we're finding that we're not really seeing impacts from these services. And this could go back to the issue that when there's ongoing conflict, much of the services in these areas are not available. And so then the question is, how do you bring in these services in these areas? I think another thing that we're finding, and is still sort of new research that we need to do, is understand better how to sustain these impacts over time. A lot of the studies on mental health usually focus on impacts of these types of interventions in the short term, so 1 or 3 months after the sort of therapy sessions end. There are now a few that are a little longer term, so 1 year out. But I think there's still a lot to learn as to how to make these interventions sustained over time. So as Michael was saying, he's finding on the ground that people are still meeting informally even after the therapy sessions end. And so whether this continued engagement is needed and at what frequency is something that I still think we need to learn more about.
I'm just going to give everyone an opportunity for like 1 minute concluding remarks to respond to anything you heard today. Michael, let's start with you.
Again, an important takeaway that we've had from our engagement with this area in Ethiopia is that these relatively low-cost, potentially scalable, community-based mental health interventions delivered by non-specialists can really have an impact. We have some promising short-term results, some cases where these results have been sustained when combined with other livelihood programming, but there's still a lot to learn. And we're excited about research that's ongoing here, and especially in some of the settings that we really feel it's critical and a critical component in meeting the felt and really strongly recognized needs, especially in post-conflict settings in the northern part of this country. So it's something that we look forward to kind of sharing more in terms of our learning over the coming period, but as well, it's been nice to share some of the exciting findings thus far with you today.
And Adiam.
In the urban space, there is some promising interventions for which you've seen results, but I think there is just so much to be done in the urban space. There is a lot of room for examining different kind of interventions. The demand is there. So I think there is a lot of work to be done on that front. And then I also agree with Melissa's and Michael's point about how do we sustain the kind of interventions that were tested. And also, I think both in the setting of the studies that the World Vision has done and also the work that we did in the urban space, these are interventions layered on existing programs that have an economic dimension. So it would also be good to test various kind of complementary interventions with these mental health interventions to see how far they could go on that front.
And Melissa, we'll give you the last word.
I think psychotherapy interventions delivered by non-specialists are very promising, especially when combined with other components, such as cash transfers. One thing I failed to say earlier, but I think they're promising solutions not just for improvements in mental health of households, which is sort of the primary outcome we were interested in, but there's a lot of other sort of impacts that the improved mental health would lead to. So improved mental health leads to improved functioning of adults, and it leads to improved labor market outcomes. And so there are all these other beneficial effects from having sort of improved mental health. And so I think the benefits from improvements in mental health due to the psychotherapy interventions are not just on the mental health outcomes themselves, but there are many other benefits as a result of them.
Thank you all for our great conversation today.
Thanks, Mark. It was great talking with you all.
Thank you, Mark.
Thanks for listening to Global Dispatches. The show is produced by me, Mark Leon Goldberg. It is edited and mixed by Levi Sharp. If you are listening on Apple Podcasts, make sure to follow the show and enable automatic downloads to get new episodes as soon as they're released. On Spotify, tap the bell icon to get a notification when we publish new episodes. And of course, please visit globaldispatches.org to get on our free mailing list, get in touch with me, and access our full archive. Thank you.